Vittoria presented me, so I don't need to give some words about it. So, but I would like to say that my presentation is strongly related to a work we did together with another institution, this Foundation Bruno Kessler in Trento, as well as Foundation EduMac. And here in my presentation, the idea was to give you like a sort of journey of the experience we had since the beginning of January 2020, and to see how we evolved during this experience, as how we try to have like a common language between modelers and public health professionals. We were directly in contact with the government and also with the National Scientific Committee, and so we were like at the front part, providing information about the epidemics, the pandemics. Does it work? Yeah. So the idea is, on the presentation, is to give this journey, dividing the different phases we consider, like the first phase, the period before the start of to find the first autochthonous cases in Italy. So from January, beginning in January, so as Lorenzo Pezzotti reported, so from the beginning of January, we activated immediately within the ISS a response team to afford this information coming from China. And then we had like the part of the evaluation during the first wave. Here you can see the main activities we performed in this period, and I'll show you some results about it. And then we have also the period, so we speak continuously about the different waves, but also was very difficult from a public health point of view to evaluate the period between the first and the second wave. So how to lift the charts during the period, and how they were driven by the possible scenario analysis we performed together with FBK. Then we have also the period of vaccination. So I will give you some details from studies we performed in this period together. And also there is the period that it was dominated by genomic surveillance. We know that after the variants started to be identified and to know how they were so important on the evolution, the transmissibility of the new waves, we will give you some evaluation of some studies we performed about these aspects. Then there will be a short focus on transmission in educational settings, and a couple of studies we performed with some local health units. So here in this case, we need to report, at least for Italy, it is very difficult for a regionalized country as Italy to perform at the national level studies involving specific settings such as schools. And so we were able to do it involving some specific local health units. And also, as the final slide, I would like to give you also the change of the severity during this period, that now we can consider SARS-CoV-2, at least with the new variants, like accepted in a normal life, although they are still contributing in an important percentage to the cause of deaths in Italy, at least in the people who are extremely aged. So let's start with the period before. So in Italy there was this incredible polemic about what is possible to identify the viruses circulating here before the first case was identified. So there were several studies here that reported that there was evidence of SARS-CoV-2. This is performed later, reported the evidence that SARS-CoV-2 was circulating. But I would like to say that in Italy, we started, as many other countries probably, using the surveillance based on in flu system to evaluate the severe cases. We were analyzed, so the National Laboratory here in ISS supported the regional labs to perform a PCR to try to diagnose these cases. But, you know, we were not able to find in more than 250 cases reported, no one was positive. Only the 3 cases reported before phase 1 was identified were the 2 people coming from China, and so they were like, there was this connection. And also there was another Italian case, but he was, in any case, was infected in Italy, but he was in contact with Chinese, if I remember well, people coming from touristic Chinese. So we were not able to find any evidence. Then we did also, so why this? So there was a way to do it. I don't think so. You know, the testing was not yet standardized and not easy to perform. Also, there were no available reagents. And so also we were driven by the fact that we were looking for the connection of cases related to patients with a history of travel in at-risk countries. And so no one was able to test people that without this history, or at least only few were tested. So to see if there was this circulation, we did also an evaluation, retrospective evaluation of data about pneumonia in the hospital registry in Italy. And as you can see, there were very few viral pneumonia before the first cases was identified, and particularly these cases were not so different expected from the time series expected cases in this period. So in general, these cases we are observing here, like in the, I don't know if I can see here, like just before first cases were identified, were online with expected viral pneumonia due to influenza in the previous seasons. So there was no evidence. We did also the analysis for Lombardy region where did this impact at the beginning. And again, the results seems to be quite similar. So in this period, so there was not so incredible circulation in the most fragile people, probably. Probably there was strong circulation in Italy since from the beginning of January and February, mainly related to young people who were in contact probably with other cases coming back from China. So probably there was a different circulation in different age groups in that period. So we were not able to identify before. So this was the surveillance we performed in that period. At the same time, in the same period, we started in collaboration with FBK to perform a SON analysis based on, to provide some scenarios about the impact of this new virus based on the reproduction number reported in China. So at that time, a reproduction number that is estimated in China was about 2.5. And in this simulation, we reported as a technical report to the Ministry of Health, to the National Scientific Committee, that with these numbers, the expectation for this scenario was very strong and very important, that this impact should have strongly impacted the hospitals in Italy, particularly the ICUs, because with this transmissibility was expected to have a situation under control in a month, probably. So then we did also like an evaluation. This is published this year, and this is a report the spatial spread just before the national lockdown. And we can see that at the beginning we evaluated that the cases were at the beginning more dispersed. So without any control, they were more dispersed. But also during the period arriving just to the first week of March, there was a reduction. But within the specific municipalities where the virus was circulating, there was still an important number of contacts. And so this shows that at the beginning the disease was spreading more with a larger distance, and then as measures started to be also not so very strong, so the circulation remained strongly limited within some municipalities. Then, so the question is, at the beginning, a lot of discussion. Maybe all of you know that in Italy, still now, we have like a parliamentary committee saying if lockdown was needed, maybe other restricted only to Lombardy or only to northern regions, or if this was needed also in all Italy. So in Lombardy, we have this data, as also here, Giorgio Guzzetta is here, reported an important publication at the beginning of March using data from Lombardy, showing that with the numbers we were observing of people being reported, the number of cases was expected to grow very quickly, and also the occupation of the hospital beds and the ICU was expected to be very strong. Here report also some other studies showing that before starting the lockdown, the strong lockdown at national level, the increase of number of hospital beds occupied in ICU was very, very high, and also assuming a different assumption about how they were growing, this was a situation not possible to be under control without any specific strong measure. So then the other question is, so was the lockdown needed in the entire Italy? And so we did an evaluation also about it, and we knew that we had like a different situation in terms of incidence of cases reported before the 8th of March. But in many other regions, although the cases were still low, the estimated transmissibility in this region was about 2.5, and very high. And so we strongly suggested to have like a national lockdown, because of the situation on Lombardy was only difference because probably the introduction started 1 week, 2 weeks before, and given the doubling time we were observing, we were extremely worried about the situation. So other people were saying, but why this strong measure? So there was a lockdown in this way needed. So there were some people saying, like, we should, maybe all of you remember the discussion about having like digitalization strategies to have like contact tracing and something like that. So again, at the beginning, we have to remember that this case with a virus with so high transmissibility, it is important to isolate a lot of people. There are a lot of studies, mathematical models reporting that you should isolate at least 80% of cases if you want to control the spread. And also, I remember a lot of people calling from the local health units, say that every day they were diagnosing more people, and they were saying that I have today like 20 cases diagnosed. I should call like 1,000 of people in contact with these persons. So immediately the local health units were saying that contact tracing in this situation was very, very difficult to perform. Also, enrolling other public health professionals working in other different units, like in chronic diseases. And if also, again, this is another point which was, again, a problem at the beginning, was the fact that we didn't have the eye testing capacity. Also, other countries, I remember also UK at the beginning, they were hypothesizing to have like 100,000 tests per day, and they were able to do it only in April. Maybe I don't remember exactly when, but you know, it was extremely difficult to perform. So then we had the impact. We measured this always with Giorgio, the impact. This is a combination. This is an analysis based on the surveillance data we were collecting. And we show that this is like an ecological evaluation. So we see that starting in several regions, we had like a transmissibility about 2.5 and 3, as I said before. And then in a couple of weeks, we were able to have like 2 weeks, to have an estimated transmissibility below below 1. So I have a few minutes, so I have to go. I have to be fast. I will go to other slides. I will skip some slides. So this is very important. That will be also the presentation by Andrea Bizzotto tomorrow. So I can only give you like we also had the problem to how to balance the reporting delay of the diagnosis, the limits of we know that the cases were reported with delay, not only from the infection, but also from the onset of symptoms. And so we know that we also manage with the reporting delay to find a way to be timely in providing these estimates, but also to have an error that is not so much in this estimate of the transmissibility. So, and here you can see tomorrow the presentation. Then the other question was after from April, so when to end lockdown. This analysis shows that we did several scenarios, assuming like more than 100 scenarios using different parameters, but particularly all of them showing that the opening school was the main problem in this case. This is maybe obvious because they are people that have more contacts among the population, and that usually they are sustaining several epidemics, various respiratory epidemics in the world. And we evaluated when to end. So to reopening the schools in April was considered too much dangerous from this type in this type of model. And we also to end the lockdown in April again was considered too dangerous. So, and we then defined as a possible decision to stop at the beginning of May, but with the school not reopened. And then September reopening. So as expected, as it was reported in the models, we observed a lot of a resurge of the epidemics, particularly we observed that after 2 weeks of the school reopening, all the transmissibility observed in all the regions was increased. Now we can discuss a lot about if this was a problem only of the school reopening, of all the aspects that are in September in the Italian countries where there are a lot of people starting to go back to the gym, to start new courses, to go at work. You know, in Italy, in August, it's a typical vacation month, and usually there are not so many contacts within the city, but there are contacts in vacation, so probably we cannot distinguish the effect, but we know that this was one of the problems. Then we were evaluating what to do for the autumn. And in this case, there was a strong collaboration between modelers and public health professionals to define a new ways to define when to start some measures in the second wave. So here there is this evaluation. We did a very complex evaluation, weekly rapid assessments based on the ECDC rapid risk assessment tool. And this was based on a lot of indicators. We had like 15 indicators participating in this evaluation. And this provided several colors to some information. So this is the way it works. And in this way, we were able to provide several indications, weekly and important indication to inform the regions about the level of risk reported, and they were evaluated. The restrictions were based on this information and were regionally based. Here also we did an evaluation of these measures. We found that using different colors of restrictions was useful, and also provided an important impact in terms of reducing the transmissibility in the periods for the different level of colors. Then there is the vaccination. So in this case, in Italy, it was impossible to have, like in Finland, to use the geographical municipality as a criterion to make a decision. There was this immediate, like a sort of constitutional law saying that we need to provide treatments equally spread in the geographical areas. But then we followed the criteria of age group and fragility. And as you can see, we had like this change. So in this case, what is very useful for us was to have, like, for data sharing, the legal framework to link surveillance individual data with national registry data. In this way, we were able to provide weekly evaluation of the effectiveness, the estimated effectiveness in Italy. I can, so I want to have I'm very late, so I'm providing you some data about the importance of genomic surveillance. In this case, we did a study evaluating that alpha was more transmissible, the gamma variant. This spread very, very early and substituted rapidly the gamma variant. Again, we have also the study about the Omicron impact. And so I'm very late, so I'm going to the last one, in case they're available, in case we can discuss later if you want. I want to be only to this one to say that, you know, there was this, in terms of communication, was not very easy to speak with media about how was the severity and the mortality related to SARS-CoV-2. And in this study, we evaluated, we estimated the real number of people infected, and then we calculated the real hospitalization rate compared to the number of infections and different periods. And as you can see, there was a very incredible changes in terms of severity of this virus. Maybe it's a combination of several aspects of the change of the virus itself, on the change of the impact of vaccination, the impact of immunity provided by the previous infection. So now we are observing like a death mortality that is like 100, maybe more lower than that observed at the beginning. So what are the lessons we learned? So we understood, so it was like a mode of the whole experience, that the strict collaboration from modelers and public health professionals was extremely important for rapid risk assessments and also decision making, at least for Italy. It is important to have a common language. Sometimes, you know, modelers are more academic people, and so we need to find a way to collaborate more strictly. And they're involved. So like there was this indication at the beginning, so they're involved in the exercise simulation event we are performing for the new plans for preparedness. And and I have to say also that this collaboration was extremely scientifically productive. Thanks. So these are the people that who strongly provided slides and studies, and very important for the results.